We are super excited to be back on the One Goal podcast today with Dr. GattiMays. Welcome.
Thank you.
So I'm super excited to talk today about the impact that Pelotonia dollars are having, and particularly at the Pelotonia Institute for Immuno-Oncology, which has been, we're coming up on 3 years, 3-year anniversary of the Institute, and something that our community has just rallied around, gotten so excited by, led by Dr. Zihai Lee, who we've had on the podcast and is a really, really special individual. So super excited to have you on. But let's start sort of at the beginning and a little bit of the origin story of you. You know, where did you grow up and how did you make your way into oncology and research and all of that?
Sure. So I grew up in southern New Jersey, right outside of Philadelphia. I think if you asked me when I was leaving South Jersey for college, if I would ever end up as an oncologist or ever end up in Columbus, the answer would have been no to both.
Yeah. What did you go to college thinking you wanted to do?
So I thought for sure, I knew I wanted to be a doctor. And so I went to Trinity College up in Hartford, Connecticut.
Okay.
And was pre-med there, but primarily was very interested in surgery.
Okay.
My father was a plastic surgeon, and so I think for me that was definitely a career-shaping exposure, just seeing how the difference that he made for many of his patients, specifically with breast cancer.
Okay.
And so when I went to Trinity, I thought for sure I wanted to be a surgeon. And while I was there, I became really interested in more public health level measures, and worked a lot with microbiology and looked at epidemiology. And through that interest, it actually took me away from medical school into public health school. Was there some event that happened that sort of transitioned your interests, or? So I think it was just the culmination of events. I was very interested in medicine, but I think when I started looking at just kind of the pre-med track and everything, I completed it. And when I applied for medical school, my first year actually, or my last year in college, I actually didn't get in.
Okay.
And so I kind of started, having a reflection upon what my interests were and said, well, medicine is very interesting, but very interested from the public health perspective. And so through that interest, I actually started looking more at public health schools and was lucky enough to get into the Rollins School of Public Health down at Emory University.
Okay. Down in Atlanta.
In Atlanta. And it was a fantastic experience. I worked a lot there. I actually worked at the CDC for a year doing an internship there.
Oh, interesting.
And it was actually right back, it was close to when the anthrax issues were arising. And so did a lot with threat agent detection and response there, and learned more about epidemiology. And through that was when I started becoming a little bit more aware of some of the exposures in terms of oncology and development of cancers many years later. And while I was down there, it was also a very positive experience because I met my now husband.
Okay, yeah.
So it was definitely, I think, meant to be that I needed to go and do public health first.
Yeah.
And then during my second year of public health school, I was in Grady Hospital as part of one of the research projects that I was involved in and looking at physical activity and looking at cancer reduction and looking at medication adherence.
So how physical activity impacts or might reduce cancer?
Exactly. And how just overall health. So it was physical activity for reduction in cancer, but physical activity in terms of improving general health measures, in terms of reducing diabetes, reducing hypertension. And during my time at Grady, I had a lot of interactions with patients. And that was really what I think realigned me with going back to medical school. And so with that experience, I decided that I would apply again. And this time was lucky enough to get into my top choice, which was Georgetown Medical School in DC.
Yeah, that's awesome.
And that was always where I had wanted to go. And so it was, again, I think it was a very positive thing that I ended up looking into public health first. And then during my time at Georgetown, that background in public health and epidemiology, I think really helped me find my way towards oncology. It's funny, as I mentioned, I think if you had asked me, when I was starting college, would I ever do this? I would have said no.
Yeah.
But I think all along it was probably what I was meant to do,
yeah.
Following the interests and the passions that I had.
Had you ever sort of in your family or sort of friend network experienced cancer, sort of at close proximity?
I have. So, and I think that was probably part of the reason why too, even when I started medical school, I didn't really think I wanted to be an oncologist. So both of my grandfathers actually passed away from cancer. My dad's father passed away from hepatocellular carcinoma. Is
that liver cancer?
It's a liver cancer. That he actually, we think, probably got hepatitis during a blood transfusion back in the 80s.
Okay.
And so
we just had a guest on the last podcast we recorded. The gentleman had that and just had a liver transplant.
And nowadays, hepatocellular carcinoma still carries a lot of mortality, and a lot of patients still pass away from it. But between liver transplants or now immunotherapy, there's a lot more hope. But I remember my grandfather, as I was about 7 or 8, I remember him passing away from it.
Yeah.
And my other grandfather passed from leukemia, which I don't really remember because I was younger.
Okay. Fascinating. So you end up at Georgetown. Your husband at the time, or person, so your husband at the time goes to DC with you?
He does.
Yeah. What does he do?
So he's actually a cancer prevention researcher.
Well, that's convenient. That's perfect.
So his name's Dr GattiMays, and he's here at Ohio State as well.
Okay.
I joke he's trying to put me out of a job, which I would be very okay with.
Yeah.
But no, we our interests kind of both converged in oncology at the same time. So
after Georgetown, is that when you ended up at the National Institute of Health?
Yeah. So kind of before I ended up at the National Cancer Institute, when I was a third-year medical student at Georgetown, that's when we started to do our clinical rotations. And to me, this was, I think, really, if you think back, that it was there one event, one experience that really made you realize what you were meant to do. I think it really was during third year of medical school. For our internal medicine clerkship, I very much wanted to do cardiology. I thought, during the first couple of years of medical school, I went from being maybe interested in surgery to infectious disease to cardiology. And I petitioned the clerkship directors and I said, I really want to go to oncology or cardiology. And they said, no problem. We'll put you in with this doctor. And then the assignments came out and they put me in an oncologist's office.
That must have been disappointing.
And I was so angry.
Yeah.
I thought, oncology, I don't want to do this. I just felt like oncology was sad and it was not what I saw my future as. And I remember I went to the oncologist's office, and by the end of the first day, I came home and told my husband, I said, maybe oncology is not so bad.
Yeah.
And by the end of the first week, I actually started thinking that oncology was maybe what I wanted to do.
Well, that's a quick turnaround.
It was incredible. I mean, I think it was once I actually saw what oncology was about. I think it just proved a lot of the myths and a lot of the things that I had heard about it, and even my personal experience. I saw very quickly that oncology is, while there are sad times, I think oncology is full of hope and full of promise and full of a very special patient population, one that we don't see in any other clinical specialty.
Yeah. What do you think it is about oncology? And we've obviously had a chance to interview a lot of your colleagues on the podcast and just talk to them in the community, and everyone always sort of references it. It's like this fun puzzle, right? And sort of trying to figure out, treatment plans and everything. Is it how complicated it is that sort of continues to drive you? Because I feel like maybe that's why you wanted to be in cardiology too, because cardiology is not an easy sort of arena to get into.
I guess I would caution using the word fun because obviously it's not fun. But I do think the part of oncology that I like is that there's so many parts of the patient that you really get to take care of, and that it's a huge responsibility to have patients really be at some of their most vulnerable moments at the time when they are, hopeless in some cases, feeling that they don't have a way to improve, that their plans have not gone as they had hoped. And I think that the trust and that doctor-patient relationship was the thing that to me was just so special, and something that is, when I see a patient in clinic even now, I mean, that's one of those really important relationships that takes time to develop. I think learning about the patient, not only about their cancer and about their tumor and what treatment plan, but what are their hopes? What are their goals? What are their dreams?
Yeah, the milestones they want to make it to.
Absolutely. In my clinic, I often call those the milestones that matter.
Yeah.
So do they have a grandchild that's going to be born in 9 months?
Yep.
Those are the types of things that I think, especially in oncology, that when we're considering the treatment plan, that we really do have to consider, because that's ultimately, we're trying to help the patient. We're the patient's advocate and trying to get them towards those personal goals.
Yeah. So after Georgetown, you went to the National Cancer Institute, right? Okay. What was that experience like? And I guess for sort of the lay person listening to this, describe the role of the National Cancer Institute.
Sure.
Know.
So the National Cancer Institute is one of the institutes at the National Institutes of Health. And so the National Cancer Institute, or NCI, is actually America's largest research cancer hospital. Most people think that it's purely a research institution, but we actually have a very large clinical program. For oncology fellowship, we actually have one of the largest oncology fellowships in the entire country, is at the NCI. And it really was incredible because as a fellow there, I not only had the clinical opportunities to learn how to take care of oncology patients, but I also received training in how to design clinical trials. And so especially as a clinical trialist and a researcher, this is the place that you go if you want to learn how to do clinical trials, because this is what they do.
Yep.
And many of the trials that we do there as fellows, many of the trials that we're involved in are early phase clinical trials. And so they're the trials that we're taking agents that were newly designed in the lab, and we're bringing them into patients for the first time. So it's a lot of first in human clinical trials, a lot of phase 1 clinical trials. And to me, that's the really exciting part of research. And that's the part too, as a physician, I feel like you have to be a really good clinician and a really good physician, a good diagnostician in order to do phase 1s. Because these are agents, we don't know how patients are going to react to these agents, to these drugs. Yeah. We don't know what the side effects are. We can't look at the FDA package insert and say, oh, well, we know that, low white count's going to happen in this percentage of patients. You really have to be extremely aware of everything the patients are telling you about how they're feeling. You have to be very cognizant about their labs. And so it's very exciting because with those agents, even though there are a lot of times the trials are not necessarily blockbusters in terms of they're not practice changing when they're that early, it's those phase 1 clinical trials, I think, are what give a lot of us hope when it comes to cancer research. Because you hear
a lot about that in the news, and
absolutely
sort of breakthroughs, and
absolutely. I think any researcher who's done clinical trials, especially early phase, even though you'll have a 20-page or 20-patient trial, and maybe 10 of them the drug doesn't work at all, and a few of them maybe the cancer doesn't grow on it, but it doesn't really shrink it. But almost everybody has that one patient that, the treatments were exhausted. They really didn't have many options left. And they were courageous enough to go on a clinical trial. And it worked for them. Yeah. And it's just, that's the part I think that also keeps us going as phase 1 clinical trialists.
What's that feel like for you because I'm sure you develop relationships with these people, and to have that sort of moment of where they were feeling hopeless and maybe ready to give up, and something works.
It honestly is one of the best feelings, and I think it's again, it's what keeps us going. It's what provides the inspiration. It's what provides the drive to keep going, especially because there are bad days in oncology.
Sure.
But you hold on to those special patients, those special experiences where the patients, it did work for them. It did help.
Yeah.
So
where along the path did sort of a focus on breast cancer sort of pop up for you?
So I think the interest in breast cancer, I think, probably goes back before I ever thought I wanted to do oncology, just given with what my dad did as his plastic surgeon.
Okay.
He did a lot of work with mastectomy and reconstruction.
Okay.
And I always thought it was very striking how special the breast cancer population was. Breast cancer occurs in 1 out of 8 women. And so there's a good chance that most people know somebody who's had breast cancer.
Yep.
And so I think that's really where the seed started. And again, it was during that oncology experience as a third-year med student that I really started to gravitate more towards breast oncology. And I think, again, there were some patients that, with breast cancer who do really well, patients who take their endocrine therapy, who receive chemotherapy and are essentially cured of their breast cancers.
Mm-hmm.
But there's other people, like patients with triple negative breast cancer, which is really kind of where my practice has turned to focus on, that, despite the greatest advances, we still have patients that need additional help, that need other options.
Yeah.
And I think it was just seeing the fact that we really do have those patients that do well in breast cancer, and we have patients that have great need, was really what drew me to breast cancer. And when I was at the NCI for fellowship, the other thing that really drew me to breast cancer was, I think there's a lot of hope for the use of immunotherapy in breast cancer. We see that there are certain types of breast cancer where immunotherapy works, and there are certain types where it doesn't. And we're starting to understand what is it that sets apart those cancers that respond versus those that don't. And for me, that was, again, I think when we look at, the future of oncology and immunotherapy, starting to understand the basics of the tumor microenvironment. So the area of the immune cells around the tumor, starting to understand the impact of the patient factors on the immune response. That was all the part with it. Breast cancer, I think there's so much going on that it really just drew me to it.
And that's some of your public health background is just continues to come back into this. And,
exactly.
That's so interesting. So how did you end up at Ohio State and ultimately at the Pelotonia Institute for Immuno-Oncology? And sort of, you mentioned early on, from Southern New Jersey. My wife is from Southern New Jersey, and she always says she never expected to end up in Ohio. She's been here for 15 years now. And, but how did that all come about? And, as you started to learn about what was going on in Columbus, what excited you?
Yeah. So, when I was at NCI, I never thought I was going to leave NCI.
It's a dream job.
It was a dream job. I had incredible mentors. I worked with Dr. James Gulley and Dr. Jeff Schlom and Dr. Stan Lipkowitz, who just were phenomenal mentors and sponsors and leaders in immuno-oncology. And I never really thought I would leave.
Yeah.
And Z-High came to me right after the Pelotonia Institute was formed. So this was, I think it was June or July of 2019.
And did you have a previous relationship with him?
No. Nope. So he had contacted a colleague of mine who was here, and they kind of both reached out to me and said, "Hey, we've got this new Pelotonia Institute for Immuno-Oncology, and we're really looking for a breast immuno-oncologist. Do you want to come talk?" And, I kind of went back and forth, but I figured, well, what's the harm in talking?
Mm-hmm.
And at the same time, my husband, who does cancer prevention research, was approached by Peter Shields here to do tobacco research in his group. And so it kind of worked out that both of us had great opportunities to come here.
They really just centered around. They found like
they're
like, oh, there's a family. We got to go get this family.
Exactly. And so, and for both of us, I think it was independently, they were both great opportunities. And then I think obviously as a family, I think it was a great opportunity.
Yeah. When you heard Pelotonia Institute for Immuno-Oncology, did you have to Google, like, what is Pelotonia? What's going on here?
I did, because I think it was April of 2019 that it was formed, right?
Yeah, so the official announcement was July of 2019, but sort of the beginning of that year, Z-High was doing a lot of work and outreach. And
I think it was like early July, because it was like right around July 4th that he reached out to me. So that's, of course, I had to Google. I was like, what is this?
Yeah, what's going on? Oh, it's a bike ride.
So, but I do remember, because I came from my first interview in September of 2019, and it was right after Pelotonia.
Mm-hmm.
And I think it was maybe the week after Pelotonia or so.
Yeah.
And it was incredible to hear of just the movement that the bike ride was and how much money was raised that year. But more importantly, I was struck by the community in the sense that everybody seemed to rally around Pelotonia.
Yeah.
And, as my husband's been a long-term Ohio State fan, and so I've known for a long time that people in Ohio are very proud of Ohio State.
They take Ohio State football very seriously.
So, kind of in having that background, I guess I wasn't super surprised with just how supportive everybody was of Pelotonia. Yeah. And again, I think that was definitely one of the drawing points for me to come.
That's something that we hear a lot, which is researchers, doctors come here and they're surprised in a really good way that the community sort of just cares at this really foundational grassroots level. How does that influence sort of your work day to day, just knowing that you go to the grocery store and you see someone wearing a Pelotonia shirt and sort of the connection back to your work is really strong.
It absolutely is. And I think it really does instill a sense of pride, that what we do at Pelotonia and at Ohio State is much more than our individual work. Mm-hmm. They're very much our ripple effects into the community. And I think when you have that support, when you go and you see the Pelotonia magnet on the cars, when you
Yard
see exactly. I mean, you're part of a much bigger movement, and again, I think as a researcher, it pushes me. It makes me think, okay, how can we get the name out there more? How can we do more with Pelotonia? How can we do more for Ohio State? But more importantly, at the root of all that is how can we do more for our patients?
Yeah.
I've been very surprised. Patients will come to us at the Stephanie Spielman Breast Cancer from West Virginia, from Kentucky. I mean, they travel from all over to come see us there. And again, I think it really is representative of the recognition and the reputation of Ohio State and Pelotonia nationally.
Yeah. So what are some of the things you're working on from a research standpoint?
Sure.
Sometimes I always say okay, explain it like you're explaining it to an 8th grader.
Sure.
Or maybe explain it like you're explaining it to your young kids.
Yeah. So much of what I'm interested in for breast cancer is, again, how to get those good immune cells into the tumor. So generally, the immune system is really good at identifying bad cells and getting rid of them. We see that all the time with infectious diseases. Somebody has the flu. Well, their immune system can recognize it and get rid of it. When you have a vaccine, that's even better because the immune system's been taught how to recognize these bad cells and get rid of it. But cancer cells are tricky because they know that the immune cells are going to recognize them and get rid of them. And so the immune cells put up a bunch of different kind of displays, a bunch of different walls or onion peels to keep those immune cells out.
Okay.
And so it makes the immune cells sleepy. It makes them so that they're not active. And eventually these immune cells just ignore these bad cells. And that's when they grow and that's when they become cancer cells. And so much of what I'm interested in is how is it that we can reawake or reinvigorate those immune cells? How can we get those immune cells to go back to do what they should have been doing?
Instead of sleeping on the job.
Exactly, instead of sleeping on the job. And so, much of what we do in oncology, I think we've learned which tumors like melanoma and lung cancer, that it's easy to just remove one of those layers and then the immune cells go back to doing what they're doing. And those are the tumors that respond really well to immunotherapy. But breast cancer is a little more complicated. When you think of the tumor microenvironment, it's not just one layer of defense, it's multiple. And so my specific interest is looking at how is it that we can combine agents, whether it's standard therapies like radiation or chemotherapy. How do we combine those agents with immunotherapy to peel back multiple layers at one time so that those immune cells can wake up and get back to work?
Interesting. What's the makeup of sort of your colleagues and team? And we hear a lot from people at OSU, it's very team-based and collaborative over there. And so what's your lab look like? What's the makeup of all that?
Sure. So as a clinical trialist, usually our lab is really in the clinic. And so much of what I do is in the clinic. It's running clinical trials. It's enrolling patients on clinical trials. But the other part of, or the other perspective of my research is translational. So I do work with Dr. Zihai Lee's lab. I also work with Dr. Dean Lee's lab of Nationwide Children's in looking at, again, kind of how do we combine agents to perhaps bring them from the lab into the clinic.
Yeah.
So much of my research since, while I've only been here for 2 years, which seems like a long time in terms of getting some of these early kind of phase 1 trials open, that's still relatively short. But I am working with Dr. Dean Lee on a cellular therapy clinical trial for breast cancer.
So this is in combination with Nationwide Children's?
Exactly. Yep.
How is that? I guess, was that collaboration surprising to you when you moved here, or is that something you expected?
So that was one thing actually that Dr. Lee told me, Zihai told me when I came here, is he said, everybody here wants to collaborate. We've got a great team environment. And he asked me kind of, what exactly do you want to do? And I said, well, I'm really interested in cellular therapy. He said, you got to talk to Dean Lee. I said, okay. And before I knew it, I had a meeting with Dean Lee. Yeah. There have been a couple other times too where I've said, this is my interest, and other colleagues have connected me with other collaborators. And so, part of me has been surprised with how willing everybody is to collaborate. But at the same time, that's, I think, why we're all in clinical research.
Yeah. How many, trials does someone like you work on at any given time? Is it one and you're really focused on one, or do you have a handful?
So in general, there's always probably a handful that are going.
Okay.
Many of these clinical trials, because they are early phase clinical trials, sometimes the concepts are developed and they never actually make it to the clinic.
Okay.
When you're basically relying on novel agents, so drugs that are not FDA approved, a lot of times you are almost at the mercy of the pharmaceutical company. So if the pharmaceutical company decides they don't want to develop that drug anymore, that trial that you were just about ready to open now can no longer open because you don't have drug supply. And so, there have been quite a few concepts that's happened to, especially with COVID. Obviously there's been a large shift in clinical research and there was a hold for quite a bit of time, not only at Ohio State, but nationally of enrolling patients. And I think we're still feeling some of the effects about that, but I'm very optimistic that we're coming out of that, and in clinical research, I think we'll be getting back on track.
Yeah.
But even without that, you've got to have multiple trials in the pipeline, because usually only one or two will actually pan out.
Yep. Let's shift gears a little bit and talk about Pelotonia. I know you're signed up as a challenger and you have some goals. I think some running goals and also some bench pressing goals.
Yes.
What are those, and how'd you come up with them?
Sure. So I love to run. That's actually on the weekends. I usually run about 3 to 5 miles on Saturday and Sunday.
I'm like a 1 mile max kind of person.
So for me, it's my thinking time.
Yeah.
I think, especially for the job that I do, I need that thinking time to just be with myself and just think about the week, that's often where, especially for patients, if I have challenging clinical scenarios, I actually think about it when I run, because that's when I think the best.
Yep.
So my running goal for Pelotonia is from the beginning of May until the beginning of August. I plan to run 100 miles.
Okay.
And so I think I actually just passed mile 33 this weekend.
Nice.
So we're getting there.
Yeah, that's right on pace, right?
Exactly. They're not fast miles, but it's in the end, it's the distance, right?
Yep, that's right. It's the journey. It's all about the journey.
It's all about the journey. So working towards my way with that. And my oldest son is funny. He's actually now decided to be one of my trainers.
Okay.
So now he's riding his bike alongside of me. So we've had to increase the pace.
Motivation,
increase the pace a little bit. But it's 100 miles. And then to bench press 90 pounds for 10 reps times 3 times.
Okay.
I think last year my bench pressing was 80 pounds times 3 times.
So stepping up a little bit.
Yep, every year a little bit more.
That's awesome. What's it like for you as a mom to see your child involve themselves in this, right? Just even a little bit, just being on your training and sort of that little bit of support.
So I think it's huge. I mean, I think, again, it goes back to really that community support. My son, because both of his parents are here at Ohio State and in Pelotonia, I think he's got quite a bit of Pelotonia swag.
Oh yeah. You're not allowed not to.
But I think, though, he understands too the importance of research, and specifically with advancing oncology.
Yeah.
And so he sees what we do, and he sees that it's for the good of improving patients' health and improving lives. And so it's been great this year. I was happy when this weekend he was like, "I'll come out and ride with you, and I'll keep you." He's like, "I'll keep you fast." I was like, "Oh boy."
Thanks. Yeah. That's awesome. Have you had a chance to work much with Dr. Farr?
I have.
Yeah. So we just interviewed him a couple weeks ago, and obviously he's retiring at the end of June. And one of the things he shared, which was so fascinating, he's been doing just oncology surgery for decades. But for him to show up on Pelotonia weekend and to see patients of his has been really special. Have you had some of those moments in the community where you've seen patients of yours and that just brings everything full circle for you?
It absolutely does. I mean, I think, I would say, so I definitely see patients in the community, but I think the part that really brings it full circle is when I see the patients in clinic and they bring me pictures of their family, of the family events, of the wedding that they attended. Those are the parts that I think are, especially, I've only been in Ohio for 2 years, so we're still, and we're still somewhat COVID restricted, so I'm not in the community a ton. But I think it's those moments in the clinic where the patients bring in that part of their lives and say, well, I was able to do this because I'm feeling better. Absolutely.
Yeah, that's cool. Because last question, sort of on the world of cancer research, what's really exciting to you about the next, 3, 5, 10 years that you see just coming down the pipeline, and like what brings you like that energy?
Yeah. So I think for me, I really think when I look back, so I've been out of medical school now. I graduated in 2011.
Okay.
And so that's an important year in immuno-oncology because that's the year that ipilimumab was approved.
Okay.
So, pretty much my entire...
So explain that for our listeners.
So ipilimumab, it was the first approved immunotherapy agent, immune checkpoint inhibitor for cancer. Okay. And so it was approved in melanoma. I think it was in November of 2011.
That's like this crucible moment.
It was in a lot of people in immuno-oncology say that was really the onset of the age of immuno-oncology. Okay. So when we look at kind of sentinel events, really what started it all, that was it. Yeah. That was the first formal approval. And, when I think back to when I was in medical school, we never even heard about immune checkpoint inhibitors. We didn't learn about immunotherapy because it wasn't approved. And so it was during my intern year is when ipilimumab was approved, also known as Yervoy that's the other name. And when I think back just in that time of how many agents have been approved, I think right now there's 8 different immune checkpoint inhibitors across different tumor types, more than I think it's now 20 different tumors in several different indications. When I think of that progress in just a little bit over a decade, that's to me the part that makes it so exciting. Yeah. Is you think of the impact of cancer research and just what 10 years can do. My patients that I treat now in breast cancer, we have immunotherapy options that we didn't even have last year at this time. Yeah. And we see tremendous improvements in clinical outcomes. And so that's the thing that keeps me going, that makes me really excited for what the next decade has.
Yeah, it's interesting. I mean, that time frame, the first Pelotonia ride was 2009. And so when 2,200 riders took to the streets in August of 2009, immunotherapy was not approved. It was not sort of the thing it is today. And, you sort of flash forward 10 years to 2019, And we established with this $100 million pledge, the Pelotonia Institute for Immuno-Oncology. And it's exciting to be a part of, what hopefully is an amazing and incredible next decade plus to come.
Absolutely.
What would you share sort of with our listeners? I imagine, the dinner table talk at your house is sometimes cancer focused. And, but like when you think back to your public health knowledge base and, what are things people should think about and can do in their everyday life that sort of might improve their chances of not sort of getting cancer and things like that?
Sure. So I think, and obviously there are specific behaviors that we know increase the risk of cancer. But before I ever discuss those with my patients, I also always discuss that the majority of cancers are things that we don't know why patients develop the cancer. And so I never want a patient to feel like they did something, to deserve that cancer. That's never the case. But there are certain behaviors, we do know that tobacco use obviously increases multiple types of cancer. And it's not just cigarette use. There's, e-cigarettes obviously are becoming hot now. And I think, while those studies are kind of the long-term effects are still to be determined, there are concerns about some of the carcinogens that are in those e-cigarettes. Alcohol use is actually a very large contributor to cancer development. And so making sure, limit alcohol use, avoid tobacco use. Exercise actually really improves patients' outcomes and does decrease certain types of cancers, for example, breast cancer. So, healthy habits I think are always important with it. But I think kind of the main thing that at least really has been reinforced for me during COVID, the number one thing patients can do is really stay up to date on their cancer screenings. I've been really surprised with, obviously, COVID really impacted mammograms. And we've had a lot more patients present to us at the Stephanie Spielman with more advanced cancers than perhaps they would have if the cancer was caught on a routine screening mammogram. So I think, that's really the number one thing is patients can stay up to date on their cancer screenings, try to limit some of those behaviors. But obviously, too, if there's something of concern, I always tell patients, tell your doctor.
Tell your doctor, And the James has the diagnostic center resource, which is amazing. And we're actually upcoming launching a campaign sort of in support of going to get your screenings. Because getting your screenings on time and those early screenings could save you a lot. So, that's amazing. Well, thank you for joining us today. It's always, we get to hear a lot of stories from survivors and caregivers and writers and a lot of your colleagues at Ohio State on the podcast, but it's always so fun to hear about the impact and the work that all of this money our community is working hard to raise, but to see it in action is always amazing. So thank you.
Well, thank you for having me.